Well, good morning, and thank you so much, Professor Hinshaw. What a delight to be here. This is a gorgeous space, and I'm so impressed with the turnout. Obviously, the curriculum is doing something right to get this many folks out early on a Saturday morning. So thank you again for being here. I thought, I might start by talking about how I got into this field of palliative care before I started talking about what it is. I grew up in the Boston area and then lived in Philadelphia for my undergraduate. And then I did my medical training in New York City. And I chose to be an internist, so I did internal medicine training. And at that time, most of the training took place in the hospitals. And what I found was, while my patients were getting really technically excellent medical care, a lot of times it seemed like there may have been not enough attention to their pain, to their symptoms, to the distress of the family, and just globally to suffering. And that was kind of a striking thing, that this mismatch between really excellent medical care and yet people still having gaps in their care. I learned then that there was this field called palliative care. And actually, I just was fortunate enough that I happened to be training at one of the earliest academic centers that had a palliative care program, and that's Mount Sinai in New York. So when I found that you could actually kind of do this for a living, that was very exciting. So then I did a fellowship at Memorial Sloan Kettering, and then went back to Mount Sinai, where I was on their faculty for 4 years before Hawaii came calling. And Queens wanted to develop its own palliative care program, and that was just a really exciting opportunity. So that's where I spend most of my time, about 95% on the inpatient service at Queens, and the rest in our cancer center seeing outpatients. So what I'd like to cover today are these objectives. I want to talk about the needs of people living with serious illness, and that's part of the talk where I might like a little bit of input from the class in terms of their experiences. I want to give you a definition for palliative care, describe its role in relation to disease-modifying therapies, because there's a lot of confusion about that. One of my mentors said that he always had to explain that palliative care does not have anything to do with the care of the palate. We're not dentists, although if you've got pain in your mouth, we'd like to help you with that. I'm going to go through some data, try not to be too data heavy, but I do have some data about the documented benefits of palliative care when it's been studied and sort of how we think it should be best combined with disease-targeted treatment, the sort of things that I saw in medical school and residency being done very, very well, but not maybe in combination with the palliative approach. And then I never get invited to speak in front of an audience publicly without talking a little bit about advanced care planning, which is somewhat related to palliative care in that we do a lot of counseling. But advanced care planning is just a really important topic and an often misunderstood topic. So I did want to spend a little bit of time talking about that too. So before I ask you your experiences, I want to just show you some of the earlier data. This data is 15 years old by my colleague Joan Tino, who was at Brown formerly, and I think she's at University of Washington now. And she just basically asked patients and families who were living with some kind of serious illness, whether it was heart disease, liver disease, lung disease, cancer, what were their priorities in addition to living longer? And these were some of the things they came up with. Physical comfort and emotional support, shared decision-making. They wanted balance there. They don't want the doctors just telling them what to do, and they also don't want the doctors just like giving them a long list of things that they could do, and then they make the choice themselves. They really wanted a partnership with their team. They wanted the information and then to have a dialogue about treatment. And sometimes it doesn't quite work out that way. Of course, they wanted their loved one treated with respect. They wanted good information so they could make the best decisions. And they also wanted good emotional support as they were going through it, both for the patient and for the family. And then some places do that really well under one roof, under the hospital roof. But then when you get discharged, there really isn't a good, smooth transition. So a lot of people said they'd really like to get that smoothly coordinated across all the settings of care, when they're at home, when they're in a rehab facility, when they're in the hospital, when they're in the doctor's office. And again, this is what sort of the data has showed us, that just as we heard from Connie, physical suffering was not adequately addressed. Nobody really talked about the communication about goals of care. But I don't know if anybody has had an issue, or, we don't have the time to go back, but think about it. A lot of people aren't really 100% clear, what they can expect in terms of time if they have an incurable illness, or is the treatment intended to cure them or improve their quality of life or just sort of extend life. A lot of times that's not clear, and actually the majority of the time in some cases there's a mismatch between what the doctor understands the treatment being and what the patient understands. So it's actually more common than not that the communication is not really, that everybody's not on the same page. Sometimes I don't feel people are even in the same library. And then this big one, I think, again, Connie touched on that one, this lack of concordance of the care with the patient and family preferences. The care, the goal was be as comfortable as possible. Well, the resident, well-meaning, had this other goal to be able to know whether she was having a stroke or whatever he or she was thinking. But that wasn't the patient and family goal, which was maximal comfort. And so there was this lack of concordance between the treatment that was desired and the treatment that ended up being given. And then these big financial, physical, and emotional burdens on the caregivers. And I think that's somewhat what Peter was addressing, that, if, money was, grew on trees, sure, we could just hire and have private duty nursing in our houses, and professionals could be providing care like that. That still doesn't, take away that a lot of people, even if it's a nurse helping you, bathing, it's still a dignity issue, but still, for many people, it's a little bit less of a sharp insult than having your children do that for you. And many people, I found, can adjust to having a nurse, a nurse's aide, or a healthcare professional with things that we normally do very personally on our own, but it is a lot harder when we're asking family or even friends to do that. And this is a big issue. And there aren't solutions to all of these. So palliative care, I told you what it's not. It's not about taking care of the palate. So this is one of the definitions. It's specialized medical treatment to prevent and reduce pain, symptoms, and stress for people who are living with a serious illness, okay? I want to emphasize the living with, okay? A lot of my doctor colleagues misunderstand it and think that palliative care is only for people who are dying from, okay? And they'll say, well, they're not dying, so they don't need palliative care. They're not dying yet, they don't need palliative care. They don't get it. Palliative care isn't about your prognosis, it's about your needs, okay? It's about what your needs are. The goal is to improve quality of life for patients with serious illness and their families. And what we do is we provide this added layer of support to the patient's regular medical care. We don't replace them, we join the team at any stage of the illness and in combination with curative or disease-directed treatments. More than happy to see people who are actually, have a curable disease that they're getting very aggressive treatment, like a leukemia. We cure a lot of leukemias these days, but people can go through a lot of, tough treatments, and they might have a lot of pain and suffering associated with it. So palliative care can work on them, but you don't have to wait until they're incurable. Okay, so it's a big misunderstanding. So here's my team, and I am blessed that Queens, really has been very supportive. This is definitely the largest palliative care team in the state, and it's a mix of people. So there are some doctors there in the middle, they're advanced practice nurses, and we have one social worker, which I wish I could clone, because we really need, she's expert, and all of our patients need her, but we really have to pick and choose the people that have the most intense psychosocial distress to benefit from our social worker. Other teams will include a chaplain, and we do have a chaplain. He just wasn't in the picture. We have a chaplain resident who we're very fortunate has joined us. So we get a different chaplain resident each year who's a senior resident, and that's wonderful to help people with their spiritual or existential challenges. So palliative care is not. It's not about giving up, okay? I'd actually say it's about fighting harder for more and better life. It's not in place of curative or life-prolonging care, okay? It's not either or. It's not the same as hospice or end-of-life care, and I think that's where people get a little confused, because the philosophy of palliative care, so hospice gave birth to palliative care, okay? When the modern hospice movement started, really in this country at the end of the 70s, we saw that people did really, really well if they got into hospice a little earlier. They had better quality of life. There's actually some evidence that people on hospice live longer than people not on hospice. But the way Medicare in its wisdom decided to set up hospice, you really had to forego any additional disease-directed treatment. So no more chemotherapy, for example, typically. There are some exceptions, but usually the focus is just on comfort, not on treating the disease. And then people said, well, gee, this approach is so good, couldn't we combine it, for people who are still pursuing disease-directed treatment, whether it's curative or whatever? And so that's what palliative care came to be. So that's, I think, why some people are confused. They still think it's related directly to hospice, just because the philosophy about improving quality of life is similar. But the payment model is different. You don't have to give up anything. So palliative care is really the best evidence-based treatment, and I'll show you evidence until you're going to ask me to stop. It's about vigorous care of pain and symptoms. It's care that patients want at the same time as efforts to cure or prolong life. I start a lot of conversations that I want to hear what your goals are, but I start with the assumption that you want to live as long and as well as you can. And some people say, you know what, I'm 97 years old, the long part doesn't mean as much to me right now. Or, they might correct me on that. But the general assumption is that most people want to live as long and as well as they can. And some people, will correct me on what their priorities are. So I can't make the font small enough down there at the bottom to actually include all the studies. So I've just threw in some of the earlier ones in there. But clearly shows that this kind of approach helps relieve pain and distressing symptoms. One of the measures we have, we were the first Joint Commission certified palliative care program in the state, and one of the things we look at is for our patients with cancer pain, within 24 hours, do we have a meaningful impact on their pain? And that means if they were severe when we met them, does it drop down to medium within 24 hours? And if it was medium, do we drop it down to mild? This has been shown many times, and we can show that for other symptoms too, whether it's nausea or shortness of breath, appetite, fatigue, and so on. Helping to reevaluate the goals of care so that people are in the same library, people are on the same page, okay, about what the goals of treatment are, and everybody understands that, the doctor, the patient, the family. We do help to ease burden on providers and caregivers, although there are some limitations within financially, and there's still a tremendous amount of unmet need for patient and family caregivers. Quality of life and satisfaction are improved with palliative care. This transition, which we hear sometimes goes really well, like to a great place like rehab hospital, but sometimes when you're going home, you're going from the most intensive level of care in the hospital to very little support at home, and that can be really tough. So palliative care can really help with that. We help people to complete life-prolonging treatments. I have patients who cannot get their radiation treatment because they're in too much pain to lie on the table, or they can't get the imaging study they need. And yet if we control the pain, they can get their treatment and do better. And then I've got this here that there is growing evidence that using palliative care actually, in some populations, has been associated with longer survival. And I'll show you one of the most important studies on that. So it's not end-of-life care. Most of the patients we see actually do well, get out of the hospital alive. Yes, a small part of palliative care is end-of-life care, but it's not exclusively. So we do meet people sometimes, unfortunately, who are in the last days or weeks of life. We do our best that we can to make those meaningful and comfortable days and weeks. But in general, we like to be working with people for months or years to help really, as you had that wonderful quote from President Lincoln about putting life in people's days. Palliative care really complements the life-prolonging therapies that people get, whether that's directed at heart disease, liver disease, lung disease, cancer. And really ideally, palliative care is done early at the time of diagnosis. And we actually were participating at Queens in a national study on the benefits of palliative care at the time of diagnosis. I'll show you the first phase of that study. So this is a colleague of mine, David Casseret, who was actually out here speaking at our annual conference just last year. And he did a study of 500 bereaved family members of veterans and found that their palliative care service accomplished all these things. People were much more satisfied overall globally with the quality of care. The earlier palliative care got involved, the bigger the difference it made. And the domains that they found the biggest difference in, while the global satisfaction was higher, these domains were particularly important. The emotional and spiritual, that informational communication piece, The care right at the time of death, like what we heard, didn't go well for Connie and her mom. Access to services in the community, well-being and dignity, what we heard about from Peter. Care and setting concordant with patient preferences, pain control, and that's what so many people will prioritize. I want to be comfortable. And I'm sorry, I don't like to do this. I put in an acronym here, PTSD, post-traumatic stress disorder. If you catch me doing that again, just throw a shoe at me or something. Okay, so this is the study I was referring to. This is big. This is New England Journal of Medicine. There really isn't a more important journal in medicine. And anybody on an editorial board for another journal, please forgive me for saying that, but most people have heard of this journal, right? This was a study that was done at Mass General Hospital, often MGH, often referred to as man's greatest hospital. So also one of our leading places, and Harvard, and some of you probably have heard of that school too. So they took 151 folks who had just been diagnosed with stage 4 lung cancer, okay? And they got randomized, and that's the highest quality you can do with a study, okay? That you take half, you don't just say this half and this half, because there might be something different in this half. They wanted to be close to the door. No, we do it randomly, okay? We randomly assign people, and so that's the highest quality study, and we look at them prospectively, don't look back, we look moving forward. Okay? And what they found here is that, just to walk you through this, in that green box, that the people that were randomized and got the palliative care at the time of diagnosis had much better quality of life. And these are 3 different quality of life scores. You don't really have to know it, but I just want to point out the p-value there is statistically significant. So these people were clearly having better quality of life. The blue bars are the standard of care. I don't know what you call that, orange, reddish, what color would you call that? That's palliative care. Lower is better here, okay? This is looking at symptoms of depression and anxiety. And so the people that were getting palliative care had a lot less depression. You can see in that first pair of bars. They had a little bit less anxiety. And then this over one is, I think, overall sort of psychological well-being. It's another scale, and it was markedly better, so less distress in the palliative care group. And then this is the one that really rocked people. And my mentor said that 3 different national oncologists called her and said, what's wrong with this study? This can't be possible. Because what happened was the people that got palliative care lived almost 3 months longer. That's actually about the survival benefit for some of the best chemotherapy, about 3 months in this particular disease. Some of our most advanced chemotherapies will have an overall survival benefit of maybe about 3 months in this particular disease. And yet you got it with palliative care. And so one of my colleagues said sort of if palliative care was a drug, the stockholders of the company would be sort of dancing in the streets because this is a really big effect, okay? And this is the study that's being repeated, now not just at Mass General, but at multiple sites, including at Queens. We're actually having really good experiences with our patients who are getting early palliative care. So where can you get palliative care? Well, that's a little bit of a challenge. Where we are in things right now is that it's mostly hospital-based in this country right now. There isn't a whole lot of community-based palliative care beyond hospice. So we're a consultation service. Some places have a dedicated unit. Queens is at 105% capacity these days. They really can't afford to have one unit that's dedicated, so we have to be able to go everywhere people are in need. That's sort of the most bang for the buck, rather than dedicating a unit. But some hospitals, none in Hawaii, have a dedicated unit. Nursing facilities, people can get palliative care in nursing facilities, both long-term care and in post-acute care. And in the community office-based palliative care program, I really think pretty much we're among the only ones. Actually, in Hilo, there is a small outpatient palliative care program. And again, we also only limit our outpatient palliative care into the Queens Cancer Center. So we'd love to see people that have heart disease or lung disease or other issues, but there are some challenges to just expanding. In the community, I mentioned already, palliative care grew out of hospice. Hospice is a type of palliative care, but it's different. Okay, it's for people who are not pursuing their life-prolonging treatments, disease-prolonging treatments, and so that tends to be how most people get their palliative care. There are some interesting models, and HMSA and UHA are 2 payers in our community who are doing very interesting things in allowing people to have palliative care that they pay for that is actually sort of coupled to hospice, but it's not hospice. So that's an interesting thing to know about. And if you're at a place that doesn't have a palliative care program, That's one of the best ways in Hawaii to get access to community-based palliative care, and that's in your home. Specialists who come to see you in your home. So I said that palliative care is growing a lot. This is the latest data I have up through 2012, which shows you the growth of hospital-based palliative care programs. And I would say Hawaii has mirrored this. Well, we at Queens are the first hospital-based palliative care program. Most hospitals on Oahu have a program, and some of the neighbor island hospitals also do too. So just a resource for you if you want to learn more about palliative care. This is Kokuamau, and I've given you their website here. I'm actually on the board of directors for Kokuamau. It's a wonderful not-for-profit organization that really focuses on these issues, getting people access to this kind of care, and it really is focusing on these essential elements. So I want to switch gears a little bit now. We'll have time for questions in a few minutes, but I wanted to, as I said, talk a little bit about advanced care planning. And I think my dear colleague, Lonnie Leary, who's speaking after me, is going to be talking a little bit on this too. She's going to be much better than me at this, so I'm just going to get things started. So advanced care planning is really important. It's about planning for future medical decisions. And there are two really important parts of it. Naming a spokesperson, someone who could speak for you if you were ever too sick to speak for yourself, an advocate, if you will, and reflecting on, sharing, and recording preferences. So when someone's designated as the official spokesperson, when they are yelling at the staff or telling them to do something, it carries a lot more weight than it's just, oh, this is an upset daughter. No, this is not just the upset daughter. This is the daughter who is the durable power of attorney for healthcare. And when the patient is unable to make her own decision, she speaks with the voice of the patient. So it's a really important thing to have an official advocate for you. So who should be your spokesperson? Well, who can best speak for you if you couldn't speak for yourself? Many people might pick a spouse. Many people might pick an adult child, another relative, or a close friend. Now, for my advanced care planning, I have chosen my spouse. I don't think I could get away with not doing that. But I wanted her to have a little backup. So I actually chose a physician colleague of mine, somebody who I've had a lot of conversations about, and I know she understands my values. And also, I've seen her in some tough situations, and I know she's a very strong patient advocate. And I know that she would support my wife, and if my wife's voice wasn't being heard, I know this person would be a tiger and get what I would want, the treatments I would want. I've had a colleague who's asked me to be the alternate to his spouse. That's actually how I got the idea. I didn't choose the same person who asked me just because I really wanted more of a fighter. So that's the important thing, though. Who knows you? Who do you trust? And who do you think is really going to stand up and fight for what you want? So again, who knows you best? Who would follow your wishes? And then you make it official. You complete a durable power of attorney for healthcare. A lot of people might do that with their financial planner when they're doing their will. They might do it with their attorney, but you don't have to. You can just do it on your own. If you go to that Kukuamau website, it'll tell you how to do it for free. Hey, my son's going into law school. You know, if you want to pay him some money in a few years to do it, that's great. But you don't have to spend any money to do this. You can do it for free. You either have to have it notarized or just two witnesses, and there's some limitations. One of the witnesses can't be the person you're designating. They can't be somebody who's going to inherit money, that kind of thing. But it's all on the website if you want to do that. And again, many people have done this, but I will tell you the majority of Americans do not do this. Okay? About 30% of Americans do this. Okay? But the majority don't. And Lonnie's going to tell stories so you understand the importance of doing it. So the first part is naming somebody. The next part is reflecting a little bit on what your preferences are and write them down. I actually, besides doing, my financial planner, or no, actually our attorney, estate planner who did our wills and things like that, he did us just a bread and butter advance directive, name my wife, name my physician colleague, but I wrote a letter, talking about what my thoughts and my values were. And that's it's not official, it's not legal, but it's tacked right on there. So the doctors can look at that and understand what my philosophy is and what's important to me. So the Kukuamau website is a great resource. Here's another one that's pretty new for me. It's at Stanford, and I've given you the website here. It gives you a template to write a letter to your doctor. And it talks about, if I'm ever sick, these are the things that are really important to me. And I think it's masterfully well done. it's beautiful because everyone's different and people can have different perspectives on what they would want. And it really doesn't make a judgment that you would want the plug pulled, you wouldn't want the plug pulled, or anything like that. It really works very well that way. And it also talks about if there's a disagreement in your family, this is how you would like it handled. Okay, it's very nice. It's very culturally sensitive. There's an opportunity. It says, if my children disagree with what I want you to do what I want. Or you can say, I want you to do what they want. You can indicate that. So take a look at that website. I think you'll find it very interesting. So does it make a difference? Is it just because you'll make me happy if you do this? No, there's actually evidence that it actually does make a difference. So here she is again, my colleague Joan Tino. I guess I didn't realize I was going to be quoting her so much, but she did a retrospective study, and people that had an advance directive were much less likely to die in the hospital, which is where most people do not want to end their life, receive a feeding tube, use a ventilator in the last month of life. This is a prospective trial. Remember I said studies that look forward are actually even higher quality. So these are 2 prospective trials published in also very reputable journals, JAMA and the British Medical Journal. And they found that in these controlled trials, advanced care planning was reduced hospitalization and cost, improved patient and family satisfaction, reduced the distress of the surviving family members, the depression, the anxiety that they dealt with, and I think Lonnie's going to touch a little bit on that in a less data-driven way, but with stories. Actually, no impact on mortality. So doing an advanced directive doesn't mean that people are going to pull the plug on you or you'll die sooner. Okay, you live just as long if you do an advanced directive, but you live the way you want, and you might pass away in the setting you want. If that's at home or the hospital or a hospice setting, much more likely to happen if you do some planning. And last point I'd like to make is about POLST. A lot of people might have seen one of these forms, and it's a double-edged sword. I have to say that I'm one of the people that was responsible for bringing POLST, which stands for Provider Orders for Life-Sustaining Treatment, bringing it to Hawaii. It's a very effective tool when used properly, but it's not for everybody. And unfortunately, we've had an issue that some docs are just giving these to their patients when they really should be more talking about advanced directives, what we were just talking about. So let me talk about the POLST form. I really am a big believer in it, but it's not for everybody, okay? The POLST form is a portable provider order, okay, describing the patient's life-sustaining choices, okay? It's the advanced directive, my advanced directive, I told you it names my spouse, I have an alternate, and it talks about my philosophy. But if there's an emergency, something happens at home, my wife has to call 911, that's in the filing cabinet. Even if she pulls it out, it doesn't direct my care. The advanced directive is helpful maybe a few weeks later in the hospital. If things aren't going so well, they'll look at the advanced directive. And they'll say, what would Daniel want? And that's when my spouse and my alternate would talk with the doctors. That's what the directive does. The POLST is for somebody who really doesn't want to go back to the hospital, or if they go back to the hospital, doesn't want to be placed onto life support or things like that, okay? And it is a physician or provider order that has to be followed by first responders, okay? So it affects care in the here and now. I'll go into a little more detail on this. It moves with the patient. It's a patient-controlled document. It translates the philosophy of your advanced directive into actionable medical orders. I don't need a POLST right now. I need an advanced directive. I've got that. It's in the filing cabinet. I don't need a POLST. But at some time, I may want a POLST. We'll talk about when would that time be. We used to have this thing called a comfort care only bracelet. Okay, I don't know if everybody ever seen one of those. We don't use them that much. They're still allowed, but basically you put that on somebody who was really very near death and really didn't want to go to the hospital, maybe wanted hospice care, and then if something happened, you called 911, they'd come and they'd say, oh, comfort care only, fine. We'll bring her to the hospital, we'll give her comfort care because we can't get her comfortable here in the home. But the thing is, most people don't want just comfort care, except maybe if they're in the last days or weeks of life. But many people would like to avoid some rigorous treatments. Not everybody wants absolutely everything or only comfort. More people are kind of in the middle, it turns out, and it's a process. And that's what the POLST allows you to do, really individualize your treatment. And so the Department of Health, there's another acronym, I caught myself, DOH, Department of Health, has adopted it, and it's recognized by EMS, our Emergency Medical Services, 911. Okay? So this is what it looks like. The first part is just about resuscitation. If somebody passes away peacefully in their sleep and does not want to have a resuscitative attempt, they want to recognize that as the natural ending of their life, they choose do not attempt resuscitation. If they would like an attempt to resuscitate them, then they choose the resuscitation. So having a POLST form does not in any way say you do or don't want it. You have to check which box, okay? That's only for people who have passed away, okay? You have no pulse, you're not breathing, okay? This is, you're sick, something's going on, maybe somebody called 911 or you're going to the emergency room. This has 3 levels of care. The comfort measures only, keep me comfortable, only take me from my home if you can't get me comfortable right here in my bed. And if they can just give you some medicine and make you comfortable, they'll do that. But if they can't, they'll bring you to the hospital. Limited intervention says, I'll go to the hospital, I'll get antibiotics, I'll get transfusions, I'll get tests, I'll get whatever you want. I do not want to be in the intensive care unit. I don't want to be placed onto life support. Generally, that's what that means. And then full treatment means I want to do everything. No limits. Okay? And so you can check, so filling out a POLST, you can make it as aggressive or as comfort-oriented as you want. Okay? But it's really not for everybody. I want to emphasize that point. I just want to show you this one study that shows that POLST can work both ways. They looked in Oregon, and actually Oregon is where POLST started. If somebody did not have a POLST, about a third, 34% of the folks died in this year. I think this is 2014, so it's probably 2013 data. About a third, 34% died in the hospital. If somebody wanted full treatment, they wanted aggressive treatment, 44% died in the hospital. They got more aggressive treatment. They were much more likely to be transported to the hospital and end their life in the hospital. Those who said no, comfort measures, only go to the hospital if you can't keep me comfortable, only 6%. So the POLST worked for you either way. If you wanted more aggressive treatment, it got it for you. If you wanted more comfort-oriented treatment, you were less likely to get to the hospital. So who needs a POLST? I keep saying it's not for everybody, and most people in this room do not need a POLST. It's really for people that have an advanced illness, people who have a very strong, if somebody's very elderly and really just is willing to go to the hospital but really doesn't want to be on life support, they don't have a terminal illness, that could be somebody who could do the limited interventions. But you really have to have a thoughtful conversation about their doctor. I don't want to be on life support, but if it's going to return me, after a couple weeks to good health, yeah, I'm going to do that. Nobody wants it, but if there's a payoff, it's when people have a very advanced illness, the payoff just might not be very good. Okay, so what we tell people is there's a surprise question. If the doctor would not be surprised if somebody might die in the next year, somebody might be in that last year of life, that's a time to maybe think about this POLST, what their values would be. Do they want to be in the hospital? Do they want to be in an intensive care unit? So really, it's really for that pretty serious population. That's why I'm saying I hope I don't need a POLST, but I do have an advance directive. Okay? Just to remind you that signing the POLST, it has to be signed by the patient or their legally authorized representative, the person that you appoint in your durable power, or it could be a guardian, or there are other ways of doing that, and either a physician or an advanced practiced registered nurse. So that's what the APRN, that's like an NP type of thing, okay? But that's what makes it an order, and that's why EMS, first responders can follow it, because it's an order. There's nothing, just because my attorney drafted my advance directive doesn't make it a doctor order, okay? But the POLST is actually a doctor order that you agree to and the doctor agrees to. It's in your best interest. So when should you do it? We really encourage people to do it in their doctor's office. If somebody's gone through a serious illness in the hospital and they actually wanted to have some limitations on their treatment in the hospital, like they said, do whatever you can to see me through this, doc, but I don't want to be resuscitated if God calls me. That would be somebody that would say, okay, you've made it through. Let's talk about it. Do you still feel the same way when you go back home? Or would you want us to take that limit off? Because without the POLST, the limits are off. There's just, because when you return to the community without a POLST, nobody knows anything other than do everything. So it's a way, if you still say, well, I want to come back to the hospital, but maybe not everything, that's the POLST. So we do think about it, the hospital time of discharge. Some people, if someone's going into a nursing home, not for a short rehab, but more of a long-term care, that's the time. So just to compare and contrast, the POLST is for seriously ill, frail people. The Advanced Healthcare Directive, anyone over 18, regardless of their health status, we recommend it. The POLST is specific orders for your treatment right now. I call it your now directive, what you want now. The Advanced Directive is about some theoretical time in the future when you might be sicker, okay? The POLST has to be signed by the decision maker, but the Advanced Directive is the only way to officially appoint a healthcare agent decision maker. So I'm going to wrap up, and we have time for questions, but I just want to summarize that palliative care focuses on relieving pain and suffering and about promoting the best possible quality of life. It be considered for anyone with a serious illness, whether it's curable or not. It can be used at any time in the course of the illness. We tend to think that earlier is better. It is really patient-oriented, family-centered. It can be combined with curative treatments, and it's been associated with longer and better life. Advanced care planning helps to ensure you get wanted care. Okay? And I think that's where I'm going to close, and I'd be happy if there's some questions. Thank you.